Good evening, everyone. I'm Dr. Linda Scott, Dean at the University of Wisconsin-Madison School of Nursing. Thank you for joining us for the 23rd Littlefield Leadership Lecture. It is always a pleasure and honor to host this annual presentation, which reflects the mission and vision of the school. We educate nurses who are prepared to lead in the profession and society, and we aim to improve health for all people. Before I further introduce our event and speaker, I would like to acknowledge that the physical campus of UW Madison on the shore of Lake Mendota is on Ho-Chunk land. As a university and within the School of Nursing, we respect the history, culture, and inherent sovereignty of the Ho-Chunk Nation and other members of the First Nations of Wisconsin. We also value the ongoing presence, contributions, and leadership of Indigenous people. Further, our commitment to teaching, learning, and research includes addressing the persistent health disparities that have resulted from our history. This is an area where nursing education can lead change. The Littlefield lectures highlight the impact we can make in the profession in society to disrupt injustices. The Littlefield Lecture Series was established to honor Dr. Vivian Littlefield, Emeritus Dean and Professor at the School of Nursing. Vivian held the deanship from 1984 until 1999, and she was also a respected professor and colleague. Vivian is highly regarded for her dedication to mentorship, and she is also passionate about nursing leadership. Her leadership inspired this lecture series, which bears her name. Vivian, thank you for your impact on the School of Nursing and for all you've done to advance academic nursing. I am also grateful to the Friends of Littlefield for conceiving and supporting this lecture series. It is a gift to the school, one which I am pleased to share with our students, faculty, staff, alumni, and friends, as well as other partners with whom we collaborate to improve health for all. In the past year, we have reflected on the impact and outreach of the school. We have also highlighted the variety of contexts in which nurses investigate and act in response to local, national, and global needs. I wanted this broad view of leadership and advocacy to be the focus of this year's Littlefield Lecture. Rear Admiral Susan M. Orsega was the first to come to mind and is the ideal selection as this year's keynote speaker. I'm sure you will agree as you learn more about her. Rear Admiral Orsega is the senior advisor to the Assistant Secretary for Health and Surgeon General. As such, she advises these leaders and their offices on a full range of programs, policies, and activities. Rear Admiral Orsega has held numerous leadership positions at the Department of Health and Human Services. She served as the director of the Commission Corps headquarters, overseeing all functions regarding personnel, administration, operations, readiness, deployment, and policy for the 6,000 officers of the U.S. Public Health Service Commission Corps, both active and ready reserve components. Further, she managed the activation of the largest deployment of these Commission Corps members in support of international and national COVID-19 efforts. In addition, Rear Admiral Orsega served as Acting Surgeon General from January 2021 until March 2021, pending the Senate confirmation of Dr. Vivek H. Murthy as the 21st Surgeon General. Prior to that, she served as the U.S. Public Health Service's Chief Nurse Officer from May 2016 to October 2019. Rear Admiral Orsega's career spans over 32 years in the Corps. She is also a subject matter expert in the realm of HIV/AIDS, nursing practice, international operations, health diplomacy, and disaster response. She has co-authored 25 articles in peer-reviewed journals and presented at 40 major scientific and nursing conferences around the world. So as you can see, Rear Admiral Orsega is well prepared to draw upon her personal experiences and perspective on the role of nurse leadership, especially in complex circumstances and environments. It is now my pleasure to welcome Rear Admiral Susan Orsega to our virtual stage. At the conclusion of her presentation, I will join again on screen to facilitate a Q&A session, giving um, Rear Admiral an opportunity to respond to questions that have been submitted through our virtual chat feature. So for now, the virtual platform is yours. Thank you for being here.
Thank you so much, Dean. I really like the band intro. Matter of fact, we need to have the similar type of intro here, virtual intro, a walk-in intro in the government. We don't have as jazzy of an intro like you have, but in all seriousness, thank you so much for the warm welcome. I really want to thank you. I want to thank Miss Temple, all of the, of course, the behind the scenes, the AV architects who are making sure that this goes off seamlessly. So thank you. And finally, all of you who've come here this afternoon. We have until I think 11 p.m. Absolutely, just joking. But it just really illustrates how much information that really we have an opportunity to talk about this afternoon. But it is an absolute joy to be here today. And I really want to particularly acknowledge the unsung heroes who've made this really all of what I'm going to talk about come alive. I mean, you've been on the public health pandemic. I mean, it is clearly a Pandora if you just stop and think about all of what we've been through. You know, the COVID-19 pandemic, public health issues have impacted all of our lives, our health, our work, our play, and our relationships. So I want to recognize all of you, your steadfast leadership, your continued conversation and influence on addressing the COVID-19 pandemic and the health of the nation. Whether it's working at clinics, institutions, or organizations, at the bedside or boardroom or the blackboard. So we're going to go ahead and get started, and I'll have you advance the first slide, please. Next slide. So that's the obligatory disclosures, and then really just as I've talked about, I'm hoping this afternoon and evening you'll really walk away with a keen understanding wherever you work, because you are that scaffolding for those who have access to the optimal healthcare. And really, many individuals, many patients, many policymakers, many of your peers are seeking answers to what they need to do for what's around the corner for public health. So we really need to be empowered to see ourselves in this light, and I'm hoping you'll walk away with a similar mindset as we walk through these objectives. Next slide. So when I think about COVID-19, I actually want to take us back to the Spanish influenza of 1918. You know, the pandemic was the first great collision between environment and modern science. Evidence actually suggests that it unfolded in the United States in January of 1918. If you have not had a chance to read The Great Influenza by Mr. Barry, it's a really rich book because it really takes you through some of the lessons learned. And evidence in that in my review suggests that it really unfolded during right at the height of World War I. In a county in Kansas, where several Army soldiers were presenting with reports of influenza of some sort of severe type in the second largest Army training encampment or base. And it turns out what Haskell County, that county in Kansas, was reporting was only a fraction of the death rate that the United States would have later that year. It killed more people in 24 weeks than HIV/AIDS has killed in 24 years. In that same year, intriguingly enough, the United States Public Health Service and Red Cross, the American Red Cross, were collaborating to attempt to concentrate doctors and nurses and supplies into one community where it was most needed, and then they would shift to the next community all across the country. It sounds pretty familiar, right? So it was an attempt where the United States Public Health Service, in fact, would supply the pay and the assign all of the physicians, and then the American Red Cross would do the same. They would supply the labor for the nurses. So this model really became the approach that was used around the country. And what was recognized in Massachusetts is that they were teaching, they were going from one site, then the physicians would leave and the nurses would stay back and provide the care. And so by October, these requests were coming in to the Public Health Service and the American Red Cross. And by October, everyone needed nurses, or they were about to, or they knew they needed to. And so the physicians would diagnose, and then they'd move to the next quarantine area. And you can see in the backdrop where that cot area where the nurses then treated. And they were many times, the nurses were actually in charge of these quarantine areas. Before the Spanish influenza, there were actually a quarter fewer nurses in the profession to begin with. They were having a workforce shortage. And in fact, with the combat intensifying in France and the war, the need was greater for the Army to have more nurses. And in fact, it was reported that 1,000 nurses were needed a week. And that was the backdrop for the Army School of Nursing and why it was developed. This American Red Cross recruiter wrote, "The work at headquarters has never been so difficult, and it is now overwhelming us. It's now overwhelming us. And we're searching from one end of the United States to the other end of the United States to root out as many possible nurses from her hiding place." That recruiter then on September 5th reported that, and that was days before that virus actually, the influenza virus exploded in that Massachusetts area that I reported. So public health, judgment, knowledge, and observation were the tenets of the profession caring for those ill in cots. And with the predictions at that time, lessons like that really should influence how we approach the future state. Next slide. This should all sound very familiar, right? So this cot that you can see picture on the screen is actually of Javits Center in New York. Very similar to the picture that I showed you in the previous slide. And one thing COVID-19 has made abundantly clear is how small our planet really is and how interconnected we are. You can travel from a flight all the way around the other side of the world in Australia, and you can get to the United States within a day. COVID-19 has impacted everything, and as public health leaders, we have to remain on guard. To even think about where we are right now with monkeypox, with 75,000 cases reported, with 30,000 of those cases in the United States. We have to remain on guard. And the importance of our role in advocating for screening and for vaccinations can help reduce the burden on our healthcare system as we continue. And it's incumbent upon all of us to raise our voice in these communities that we serve in of greatest need. And COVID-19 is that backdrop. It prepares us. COVID-19 has prepared us in a way to get us to that new stage so that it doesn't disrupt our daily life, with really four main goals that are articulated in the United States government strategy: protecting against and treating COVID-19, preparing for new variants, avoiding shutdowns, and fighting the virus abroad. These are tools in our toolkit that has helped us and certainly should help you all to be preparedness warriors. Next slide. I want to change to something that has really become more and more aware, that we all have become more and more aware of. Certainly the emotional weight in the recent years with COVID, with the reality of what's going on and continues to go on with Russia in the Ukrainian war, really brings to the forefront a challenge that hits all of us, and that is the mental health. The research from Boston University's public health shows that depression rates in America jumped from 8.5% in 2019 to almost 33% in 2021. And if you look at the mental health in the youth, the facts are sombering. The Surgeon General, Dr. Vivek Murthy, pointed out in an advisory that he issued in December that mental health challenges were the leading cause of disability and poor life outcomes in young people, with up to 1 in 5 children ages 3 to 17 in the United States who reported a mental, emotional, or developmental or behavioral disorder. And about half, and according to that advisory, about half of the 7.7 million children who have treatable mental health disorders, about half of them didn't receive adequate treatment in 2016. There's a staggering number of kids who just have not gotten enough help, and that has only increased, as I mentioned. So it's depression and anxiety symptoms for youth around the world have doubled during the pandemic, and that's articulated in the report in the center of your screen you see. And we're looking at the suspected suicide attempts that were 51% in the report, and the clinical data is showing for adolescent girls, and 4% higher in adolescent boys compared to that same time period in early 2019. The suicide rates among youth in ages 10 and 24 in the U.S. have increased. So the general population, along with healthcare workers, are overwhelmed and overworked. And if you look at mental health, it impacts a triad of care gaps, economic costs, and investment deficits. And I'm going to walk you through them. The first one is care gaps. Despite the universal nature of the magnitude of the mental ill health, the gap between the mental health services and the supply still remains substantial. Relatively few people around the world have access to mental health services. The global number of healthcare workers is 13 for 100,000 people, according to WHO's Mental Health Atlas. That's the global median of mental health workers, 13 for 100,000. There are serious gaps, and that is obviously translating and resulting in a chronic and underinvestment across many decades in mental health promotion and prevention and care. Number two, it's the economic cost, the loss of productivity resulting from depression and anxiety, two of the most common mental health disorders, cost the global economy US $1 trillion each year. So it costs the global economy $1 trillion each year. And number three, the investment deficit. And this one is the most striking. On average, countries spend just 2% of their national health strategy budgets on mental health. And this has changed in very little in recent years. And despite this increase in awareness of mental health, in awareness of development of the need for mental health strategies, it's never exceeded 1% of their national health budgets. The good news, because there is some good news of this, is that certainly there's a return of the awareness in ways that, particularly here in the United States, that it is scaled up. General health workers from across all multi-healthcare professions are now really trained to diagnose for those who are physicians or nurse practitioners or PAs, and then also how to treat mental health conditions. There's also a wraparound and awareness of how to reach out and do regular health checks, bringing screening out to the streets to ensure that individuals who have severe mental health disorders and challenges, that their needs are addressed. And that streets all the way out to those who may have homeless population. What we can do as nurses is continue to make that awareness and to take that stigmatization out of the mental health conditions. Because the more that we do that, we will promote the strides in mental health legislation, policy development of quality community and affordable community-based mental health services. We can start earlier screenings, interventions, and have those discussions, whether it's at schools, in boardrooms, at the bedside, and really increasing those efforts to focus on more preventative care rather than crisis care. And finally, those partnerships that I know you all do so well, but building those partnerships in public and private sectors across the healthcare sector and outside of the healthcare sector will take us into making demonstrable impact. Next slide. So what's around the corner? I think prioritizing equity, COVID-19, focusing efforts around the marginalized communities and public health and really expanding telehealth and telemedicine access. As nurses, we go to where most don't go to provide care for the vulnerable and underserved populations. We work on the forefront of medical challenges, from COVID and cancer to even opioid crises, because that's where we can translate and make the most impact during the communities to that broader mission of the nation. All of us need to partner. We need to think of ourselves as critical partners within the communities to expand access, expand awareness of vaccines, from flu vaccines, seek partnerships, seek collaborations, non-traditional collaborations with researchers and funding organizations that you have who are trusted leaders within those communities. Those community-based led solutions will build that gap that we need to address healthcare. Healthcare-centered family health and strategies around public policy is really going to take us into the next 10, 20 years. Achieving that goal of healthy people will really require us to address those social determinants of health, which includes both social and physical environments where people are born, where they live and they work, and where they age. And the data needs to accurately represent and equitably drive those solutions for all families. So what this does is it translates into a national research agenda that is full and rich, along with clinical trials, community-based research, and data collection that's equity centered, really reporting on those high-risk settings. Data to inform those equity-centered response decisions will ensure that we're addressing all of those populations, but we have to do it in real time. So that's going to require us to have those conversations and raising the hand, putting 2 and 2 together, knowing that, for example, monkeypox virus is in many populations is those who are HIV infected are also impacted by monkeypox. So expanding that dialogue in those areas, we know that there are issues with disparities in health access in our homeless population. So raising that hand and thinking widely will help us to really strategize for nursing. You're all a part of this elite group in this country, and you influence public policy discussion from a nation that's faced with so many diverse and complex challenges. But because of your position and all the things that you've done, it's undeniable that we can make an impact. But we have to think about ourselves making an impact in all walks of life, from government to business to clinics, outside of the healthcare sector and academia, and really using strategy documents can drive that change through the gaps in the programmatic needs. Next slide. Perfect. Thank you. This is something that I wanted to make sure I shared with you. I guess I'll stop and ask you all, given what you see on the news, and I took this picture a few weeks ago following the hurricanes that had swept through Puerto Rico and the current conditions that were going on in Ukraine. And then at the same time, oddly enough, there was a strong earthquake that really left 2 people dead. I just ask you the question, what would you do right now if you were in Ukraine, if you were a nurse? Would you run towards that disaster? Or would you stand back and wait until they called on you? And, my experience has been that the disasters really shape our professions, and we all have roles, and there is no right answer, whether you run towards the disaster or you wait in the wings, because all of those roles are needed. We save lives and improve the efficiency and the effectiveness of the human ecosystem, all of the things that are going on right now. And you are investing in strengthening the ability of our local institutions, our hospitals, all the places that you work, to help communities prepare for future disasters or humanitarian or public health crises. We have to see ourselves in the role. Let me give you some good example of how I know that you all are doing this. Nurses are demonstrating, they're adapting, they're scaling novel approaches and tools to ensure that there's quality and efficiency with public health response by working with interdisciplinary teams. You did that in COVID. You do it for those of you who work in hospitals and preparing for whatever crises around the corner. You're providing fast and flexible, trusted, and really catalytic programs that are impacting health equity. We need to think about it in all the spaces that we're working in, like in that public health, being focused on public health preparedness. We're speaking with policymakers to seek funding and policy changes so that we're driving programs for rapid disaster relief efforts so that all vulnerable and impacted populations can have access to the resources. And finally, nurses are advocated really for that culture of learning and innovation in education and in the humanitarian sectors around the world. But we have to do more. And we have to intentionally and consistently represent our values of optimism and collaboration, but really to think widely outside of those typical spaces that we've been in. We have to consider all the things that are going on, because there will be more around the corner. And nurses are pivotal in safeguarding the public. Sometimes we face both crises simultaneously, like we're doing right now in the world. Multiple crises happening, like I showed you on the picture. But we educate and we protect people, and we have to continue to focus on that. When I looked in preparation for today, I was looking at what we've done over the past year and what certainly all of us as nurses have done. And there's some lessons. There's some lessons that all of us have, but there's some lessons in COVID that we need to immediately apply to the monkeypox outbreak that has occurred and is now, fortunately, the numbers are going down. We can do that. We can do that because both of those infectious disease challenges pose different solutions, but each of them really remain the same in seeking in a few things. One, by seeking the information, the clinical and the educational measures, ensuring that there's equity and there's adequate distribution of the treatments that are needed, and the public health and the research measures. We operate under this ethos that bigger and faster is going to get us where we need to go. And the maps certainly does show us where we're headed, and the weather does too. And COVID rates tell us where we're going. but the writing is on the wall. And it's time for us to be proficient as public health leaders, because there will be another public health disaster that's going to call upon us. And so that see what happens approach is really no longer an option for us. And we can't hit that snooze button. We have to be fully wide awake and fully alert, because we can no longer wait to see what happens the next time. Next slide. I just want to take a moment to describe the uniform I wear. The Public Health Service was established in 1798, and it is led by the Assistant Secretary for Health, with daily operations overseen by the Surgeon General. We're 6,000 officers who are assigned in a variety of different places across the globe. We wear the uniform because of that rich history I talked about, and we are assigned in a variety of different agencies under the Department of Health and Human Services, such as CDC, the NIH, the FDA. And while we are assigned to do the work that we do, and in the Indian Health Service, we can't be deployed. And we're deployed by law as directed by the secretary or the president. So we wear really two hats. Last year, we had our over 2/3 of our deployed officers. And as the former acting Surgeon General of the United States, I really my vision was to make sure that our legacy was preserved as those American health responders, and that we were that united front standing as those public health warriors of today and tomorrow. We're very fortunate to have legislative changes made that allowed for the reserve component. Many of you may have heard of in the uniform services, you have a regular and active duty full-time, and then you have a reserve component. So if anything is of interest to you as I'm talking about the United States Public Health Service, and you may be interested in either being a full-time or a part-time reservist, please look on our www.usphs.gov website. Our policy, what was exciting and why I wanted to share this with you, is taking COVID-19 and leveraging that critical time to really make the case of an increased workforce. And so we made the case, and then policy and law changes were done that now have allowed for us to have this funding and activation of our reservists where we needed them as additional surge capacity to serve the nation. Next slide. So throughout my career, I have grown to understand that you can lead in a purposeful and a humble way, and by working really in any environment. And with my previous experiences working overseas, establishing in very complex environments, establishing operations, and sometimes in countries that were facing political instability and crises, I recognize the value of these points right here, that cross-sector and cultural collaborations. It can be applicable whether you're working in the Congo or whether you're working here in the United States. The biggest challenge I feel each day as a leader is to ensure that I can take in as much information to make the most informed decisions and to really integrate the nursing's capabilities in our health service, to change the thinking of how nurses can be leaders, because we are all trained and we're ready and we are an asset to preserve the public health. But we have to change the thinking a bit in some environments of how we are there at that national scaffolding for healthcare delivery solutions. We're conveners. We need to look at ourselves and see ourselves as conveners. I'm originally from Pittsburgh, and I grew up and I was immersed in the Steelers football world growing up, and I remember many plays at the last minute of the game. And as nurses, we do not have to do a Hail Mary throw to solve health equity or to solve the public health challenges. We have all the plays in the playbook. And with our rich history, and all of our Super Bowl MVPs to learn from and reference, we can be those public health pandemic quarterbacks. But we have to be determined to throw that ball with discernment. We can't be those wide receivers sort of waiting for the other professions to pass that healthcare solution ball for us to catch it. Or we may be sitting on the sideline. So it's in closing, it is our time as nurses, working together with a commitment and a solidarity and thinking innovatively, executing on those out of the box strategies, taking some risks, knowing that sometimes those risks you may fall down, but you'll back out and go look forward and find a different solution. Because at the end of the day, we'll be building a safer and a healthier world for all of us. And we are investing in those dialogues that are focused on vulnerable populations. So just as influenza shaped our history and our profession, COVID-19 is going to be a story of science and discovery and how we change the way we think in the faces of crises, whether it's the programs or the policies or the practices. It should be the turnkey moment. So let us look back to learn how to look forward. Thank you.
Thank you, Rear Admiral Orsega, for that, your perspective and insight. And I'd like to probe a little bit more into some of the comments that you made, and then invite our audience to pose questions as well. And I guess I want to start with another outcome of the pandemic was recognizing that our public health system was fractured. Your thoughts about how we can rebuild and what are some of the first steps that we should engage in, especially as we need to be proactive in preparing for a potential next pandemic?
Thank you, Dean Scott. It's a really important question. I'm going to offer two thoughts. The first one is we all know that historically, public health departments really rest in different places across all the different states, and oftentimes they're under-resourced. Much of the strategies that we've all been talking about, and I've been talking about, are really bolstered around the expansion of public health departments. So it's really opening that door. If you haven't, scheduling that initial dialogue, prepare and talk about what you really want to get out of that dialogue, but introduce yourself as a first starting point. The second point, and certainly I'm not, as a government official, I'm not suggesting that you do this in your work capacity, but you all have a very powerful impact with your legislators. But you have to be informed about it. And so looking at both your state and your federal legislation, that they're examining pandemic preparedness, get familiar with that. And then talk to and introduce yourself to those legislators, and then talk to them about what your perspective was, what your story is, and how some solutions that they may think that they could expand, either community-based led solutions or increasing the capacity to be better prepared. So those are two thoughts. Again, I could speak so much more, but those are two thoughts that I really come to mind.
Mm-hmm. Well, thank you for sharing that. I'm also interested in the conversation that we had, or that we were talking about mental health and the escalating prevalence of mental health issues. And people are continuing to experience great stress and chaos in both their personal and professional lives. What advice do you have for health educators, and particularly nurse educators and students, and for those caring for individuals in other healthcare settings, to engage in meaningful prioritization of their own well-being and human flourishing?
It's so it's one of those easier really easier said than executed. A few thoughts. Number one, targeting the question to your populations. And I'm going to first talk about how to be educating the populations you're working in. I think you have to open up the discussion very differently in an individual who may be 70 years or 80 years old versus a Generation Z population. So if you're familiar with the Generation Z population, they are very much about wellness and mental health. And it is not a forbidden word to talk about that with that population, the 20, 30-year-olds, because they're seeking and they seek out that need to have that work-life balance versus your 70-year-old, your 80-year-old, and your 60-year-old plus. I mean, that's a population that when growing up, we learned that it was there was a lot of stigma behind it. So I think really the first thing is make sure you know the population you're speaking to and be familiar with the language. And then those solutions may not be a one box for all. But it's starting that dialogue and incorporating those who are at the bedside at the very, as they're going through, during sort of I'll say, step off the treadmill a bit and start to think about what type of, before you are going to talk about mental health, do the strategic pause and then ask them if there's anything that's going on in a very open way. It's how you ask the question. If there's anything that's going on in their life that they wanted to raise with you that they've been struggling to bring up. And that opens up the door. And then in terms of ourselves, that is something that certainly I'm very fortunate because I work in the Office of the Surgeon General, where health and wellness is part of that daily and that rubric. So it's incorporating it in our own. And health and wellness is very different for all of us. But it's taking that time to take care of yourself. Again, it's easier said than done. But if you have a organization, or if you're leading an organization, to make that part of your priority, it can be easy as in having connecting sessions with your team members, to do meetings like walking outdoors. Very easier said than done, but it is a strategy that just a couple strategies that I offer.
Okay. Thank you. And we are looking at doing some of those activities within the School of Nursing. We have a Wellness Action Advisory Committee that's led by a wellness officer, and we've actually also just embedded a mental health provider in the school to try to provide those kind of resources and really look at developing a sort of a community of wellness. So yeah. I think we really need to make sure that as clinicians that we ourselves look at health and wellness for ourselves.
Yes, no, absolutely. Just one last comment. I mean, if you can make it fun and be okay with, in fact, 2 years ago, because of the stress, I started a workout. Was sort of let's do some sort of physical fitness. It was like 15 minutes of physical fitness fame, and it was the connecting piece. I mean, for many of us, we were just happy to be on that virtual screen or in the same room, just having fun. And I think that while it was targeted to physical health, I think it ended up becoming more of a mental health lift than intended.
Sure. Well, let's shift back a little bit more to talking about leadership and advocacy. And those are two concepts that are closely related. Can you reflect on a moment on how you believe nurses are uniquely positioned to advocate for those whose voices are unheard? Or, we talked a lot last week at the American Academy of Nursing about nurses being out loud. What are your thoughts about that?
A couple things. First of all, we need to be better storytellers. We need to tell our story in a way that resonates, and it particularly resonates with policymakers. And I'm not just telling you this because I'm here at the Department of Health and Human Services, but we have the tools. And earlier in the screen, when I was presenting, I talked, there was a pop-up of the Future of the Nursing report for the 2020-2030. That is produced by the National Academies of Science and Education or Engineering and Medicine. And that is a congressionally chartered group. And so that policy, the Future of Nursing for 2020 to 2030, can be sort of the piece of paper that you reference, but to tell your story with those policymakers in a very specific way with the ask up front. I'm looking for opportunities that we can increase. There's a gap currently in the number of workforce we have in XYZ education program. This is backed up by the Future of Nursing 2020-2030 report. We're looking for your support. That opens up, that's a quick 2 sentences, but have your story in the background where you can go into deeper discussion. That would be, in my view, our biggest way that we can be strategic advocates, and its return on the investment is the leadership. Mm-hmm. And then we will be recognized, as we should be, as those leaders.
So one of the questions that we have from the audience would like to hear a little bit more about what your recommendations for that, especially how do we as nurse educators help to prepare the future generation to be better advocates and leaders?
So one of the specific things that I would encourage and all of you all in thinking about, and if you haven't heard me refer to health policy, I'll say it again because we have for years talked about reports, but it's now, I would say, targeting in your education to your students around those health policies, around those, and I'll give you a very good recent example. There are a variety of different legislation movements that are in any of the subject areas that you're interested in. And how you can be more informed is looking at whatever your state legislation focuses or your national representative is focused in, and then taking a specific cross-check to look at what acts or what policies are they really looking at. There's one recently that just comes to my mind, and that's called the Pandemics Act, and that is looking at really preparedness, health preparedness, and use of technology to be better prepared for us in the future. So it's really, I would say, becoming more familiar with a specific policy where you then can examine it and to see where the gaps are, and then speaking to those healthcare policymakers to make specific strategies is how I would to provide a targeted response.
Okay, great. So I'm going to stay in this vein just a little bit more because there are questions both on the education side related to population and public health, as well as back to the infrastructure for our public health systems. So some of the questions, when you think about nursing education, we did that shift to being more acute care focused with little public health, community health. And we also saw a decrease in public health, population health, graduate programs. What are your thoughts about preparing our future workforce in public health? And what do we need to do to advance that?
So a couple things. So I would suspect that most individuals that come out of your program don't realize that they are public health ambassadors or public health warriors. So it's thinking about it not only as a specific entity, but considering it in all of the components of education that everyone's involved in. And to be specific about that, if you have a nurse who is working specifically at the bedside, talking to that nurse as you're educating them, and say, make sure you add in some discussions with your patients or your populations around public health. And so what that means is thinking about where that patient is going to get discharged to, but talking to them and trying to understand where are they going back, where is their environment that they're going back into. And then thinking, as the second part, really thinking macroscopically and having the students think about what trends are in specific areas of populations they may be seeing. And if those trends are consistent, what measures they can take to influence really the decision makers, or if they're in the opportunity to diagnose and treat, kind of expressing and following those trends. And then the final point that I'll say is, don't forget that there is having the relationships with other individuals that are non-health related or non-health related fields, and bolstering that will be impactful to make inroads into public health. So those are the folks who are in the community boards. Those are the schools that may not be able to afford a nurse, but partnering with them to think about what's really important for the public health of that specific area where they're either teaching or they're providing services to.
Mm-hmm. So in Wisconsin, we've really seen a deterioration in our public health workforce. And we're not alone in that. I mean, we saw that in many states. Are there conversations that are occurring at the federal level to try to encourage states to restore public health nursing leaders and the overall public health infrastructure within each state? And the a collaborative partnership across state and federal agencies?
Yes, I mean, you see with COVID the sort of diversity of approaches across each of the states and how they look at public health. But what we're seeing at our level is reaching out to those specific states and to really have actionable changes that are across all of the states at one time. I'll sort of to give a very specific example. With respect to COVID, there's a focus to make sure the states, the governor's offices, all are cross-talking and also using the same, I'll say, template, if you will, to address most specific to COVID or even specific to other viruses that we're seeing, sort of bringing everyone around the table. So then the next part of that question is, well, how can nurses be more engaged, and how can they be part of the workforce changes? So we're seeing more federal through workforce strategies and workforce policies, particularly if you look at HRSA, some of the workforce planning. There's intended expansion of public health nursing in those workforces.
Yeah. Okay, thank you. There are still a number of questions that are still speaking about public health, the infrastructure and the workforce. Can you speak a little bit more what it means to be on guard for public health emergencies across sectors?
It does sound a bit daunting, but I will say, thinking about all of our roles, and when I say public health, I mean public health crises that could be of significant consequence, where there was, just for the purposes of this, if there was a major accident that occurred that impacted your whole community, your region, an explosion, a train wreck that required that was impacting the infrastructure in such a way that it was that it was causing everything to come to a standstill. We as nurses have to be one step ahead and to have those plans in motion, or to raise the awareness within your hospitals or your clinics on what you're going to do. Because we know that few countries are really prepared for an outbreak. And so if there's another RSV, take that for example, what dialogue, what are we doing right now? What are we, all of us doing to make sure that we are one step ahead and equipping our nurses to ensure that they can be ready to respond if hospitals have to pivot and have flexibility in the hospitals to be able to take care of potential patients. Do all the nurses have the education? Number two, do all of the nurses know how to see RSV? Or the original example I said, does everybody know what to do if there was an all hazards emergency? That's the kind of specific skill sets that, in my view, we need to be better prepared to address.
Mm-hmm. Can you speak a little bit more on how you're helping public health nurses to get more involved with telepsychiatry and advocating for this form of treatment throughout the country?
Thank you. That's a great a question. The Office of the Assistant Secretary for Health has really looked at partnering and establishing broad agreements and with telehealth programs. I think psychiatric telehealth, and I was mentioning that Pandemics Act previously, that has a specific statement in there, and so policymakers can be informed of what they need to be equipping, or how do they equip for psychiatric telehealth nursing. If you look also at the Surgeon General's report, there's some work around the importance of telehealth. So those two, both a policy change and then mandates that, or not mandates rather, but reports that the Surgeon General advises, really serve as blueprints, and followed, as I initially said early on, by the importance of establishing agreements to better understand how telehealth can be looked at, and how it can be addressed. It's different in each of the communities. So the federal government typically doesn't try to reach over and influence specific states or local communities how to do it, but we try to provide a broad blueprint or underscore the importance of one strategy over another. And we know telehealth requires more infrastructure, and we also know telehealth requires more expansive understanding of how it can be addressing the populations, and certainly the psychiatric and strategies with telehealth is a whole novel approach. It's not really novel, but it's a whole approach that we really need to look at it from multiple levels, both from the standpoint of policies and the government, whether it's federal, state, or local government.
Rear Admiral, you touched on this earlier in part of our conversation about wellness and human flourishing and strategies for engaging in wellness activities. Are there any conversations or work being done at the federal level to combat burnout and the ongoing nursing shortage? I know you spoke to the Future of Nursing Report 2020-2030 that does speak to clinician well-being. We know the NANSM reports that are out there about, again, clinician burnout. What are your thoughts about that?
Mm. So recently, the Surgeon General put out really a workplace mental health strategy, and that framework that was placed really emphasizes the connection of the well-being of of workers, employees, with and health of organizations. In other words, how we treat each other and how we lead teams and how we take care of each other translates into a better workplace. And so the Surgeon General, who just released this probably less than a month ago, really that was the impetus behind that was the great sort of what we're seeing, the great resignation. So why that's important? While it seems on the face it's not a strategy that is going to open up the floodgates of bringing in new workforce. I will tell you, it is significant because it's opening that door of dialogue and having individuals at all levels of the government, and including the most senior levels of the executive branch, to understand the importance of this. So that report really walks through an organization how really a framework to then to ensure that that healthy workforce is addressing or a healthy workforce is really being that foundation of the delivery of health. That's the one point. The second point is all of us in the federal government is certainly aware of the workforce strategies. So I mentioned a strategy that we're using for reserve, to build out a reserve component. I know other areas of the federal government are looking at grants, expansive grants, as well as the national strategies to look at workforce. It's going to take a huge dialogue, though, a dialogue that's going to have to cross multiple sectors to look at better incentivizing for nurses, in addition to pathways and bringing in our pipeline of new nurses to build out and continue to meet the demands of the healthcare industry.
Mm-hmm. Well, speaking of workforce, and you mentioned this about the importance of diversification and increasing capacity and representation. And I know that that's significantly important too, yet I value hearing leaders share directly from their perspective why a diverse workforce is needed to improve health outcomes. Can you recap your thoughts on that or speak to how we can
Yes.
to move the needle on this?
Oh, sure. Yes. I mean, if you look at reports, there's actually really some significant reports that illustrate that delivering healthcare in areas and populations, whether for those who may come from a background that know what it's like in an underserved area, having people who lived in that area before or grew up in that area have a sense of connectiveness. There's multiple studies that have shown that if you look the same as the individuals you're treating, there's an opportunity for those individuals to feel a sense of trust. And so that diversity of workforce is critical. And if you're challenged by that, then it's the next step is making sure, and I think we all have an obligation, is looking at particularly those who are leading organizations, look to make sure your workforce really has that diversity, so that you can treat all populations, all walks of life, so that it ends up translating into individuals who will feel that trust, have that care delivered to them in such a way that is impactful, and they understand the significance of, or understand that the person is carrying them, has that sense of connection.
Great, thank you. So we have a number of young nurse leaders and others who are considering career paths. Other students who are watching or will watch this presentation. How would you describe opportunities and challenges in the nursing profession, and why is this still, one of the best careers that one can be a part of?
It is, I would say, first thing, the opportunity for nurses are really boundless. I think most of us go in because we have a sense of a desire to make an impact on individuals' lives, to care, to deliver care, to be innovative, to design research, expand the reach to those who are underserved. I think what I would say is nursing is boundless, and there are more opportunities than just sitting and taking care of that patient at the bedside, and that we have you can make inroads in public health, you can make inroads in policy, you can make inroads in practice, you can make inroads in program, or you can make inroads in protocols and in research. So there's so many opportunities for nurses to make impact in improving the health of Americans. It's just, but looking at it very broadly rather than looking at it from the perspective of being just delivering care.
Okay, great. Well, there is also a question about the USPHS site, where it says that the max age is 44 for those who serve in the Corps. How would you suggest someone older than their mid 40s get involved if they wanted to help?
I would say two things. There is a program called the DMATs. They're a federal disaster medical assistance teams that I do not believe they have an age gap or an age restriction. And the second is volunteering in your communities, volunteering with your state boards of nursing. Really, those are three other really ways you can get involved in addition to outside of the United States Public Health Service.
Great. Well, I believe it's almost time for us to bring our audience questions to a close and to wrap things up for the evening. But before we say goodnight, I'd like to take a little bit of personal privilege to ask you just a few questions about your own habits and leadership style. So, what are a few words that others would use to describe your leadership style, and why would you select those?
I would describe myself, or others would describe myself, as a humble leader, a service, and dedication towards mission, and finally resilience. I have been in so many different challenges throughout my career, but I've always been very solution driven, and part of that is because of the tools that I've either been given as a result of opportunities that I've leaned in, raised my hand and said, I think that, and took a challenge and a risk. And because of that, I was afforded other opportunities because as a result of how I performed. It always hasn't been easy, but it's that service and that dedication and resilience that has led me to where I believe I've landed in my part of my career.
Was there a leader or mentor that impacted your life or your career the most? Someone that really stands out to you?
there are many leaders, not only within nursing, but outside of nursing, that have impacted my life. And it's just in so many different ways that have broadened my horizons and really challenged me, and then also and had the trust in me to succeed.
Wonderful. So, first, I'd like to thank everyone. It is now definitely a time to bring our session to a close. Rear Admiral Orsega, it has been my pleasure to hear your insights that you've gained throughout your vast leadership experience. I'm confident that our viewers will take away valuable information and inspiration to step into leadership and advocacy when and where needs exist. And it was a pleasure actually seeing you in person last week. So, again, thank you for being here. I'd like to thank our audience members for joining us and providing thoughtful questions. We are so appreciative of the opportunity to connect and engage, whether it's virtually or in person. So thank you for sharing your time with us this evening, and I hope you enjoyed our presentation. And I would also like to thank the members of the School of Nursing faculty and staff for planning and supporting this event. Um, Again, thank you for being at our 23rd Littlefield Leadership Lecture, and I hope you have a good evening. Good night.
Thank you. Have a good evening.
Good night.